To present on an update on management of heart failure with preserved ejection fraction. The focus will be on this session only. The other session, like heart failure with reduced ejection fraction, will be presented by possibly other presenter. So just before proceeding to the presentation, let us see this case. A 60-year-old female patient presented with dyspnea on ordinary exertion, with worsening over time since 3 months. She also reports excessive fatigue. She is hypertensive for the past 2 years on amlodipine 10 mg daily. Her current blood pressure is 140 by 90 millimeters of mercury. Pulse rate was 80, respiratory rate was 20, and saturation was 95% at room air. Chest was clear. ECG was, she was in sinus rhythm. There were no pathologies. Echo was normal with EF of around 52%. So the questions are, what is the best next step in the workup of this patient? And the other question is, what treatments would you start for this particular patient? So how often do you see a patient coming to with symptoms of heart failure and you x-ray the patient has frank pulmonary edema, you order echo, but the echo turns out to be normal. So we will discuss about these scenarios. So heart failure is a complex clinical syndrome with symptoms and signs that result from any structural or functional impairment of ventricular filling or ejection of blood. Today's session will be heart failure on preserved ejection fraction. So the definition is like patient who has symptoms and signs of heart failure. The symptoms could be prior symptoms or current symptoms. The other is the LV ejection fraction should be at least 50%. And you should have also objective evidence of cardiac structural and or functional abnormalities, which is consistent with the presence of LV diastolic dysfunction or raised LV filling pressures, which includes raised NPs. So you can see the asterisk. The asterisk shows that if a patient was previously having overtly reduced left ventricular ejection fraction, like less than 40%, and currently improves and the ejection fraction is at least 50%, this patient should not be considered as heart failure with preserved ejection fraction. Rather, it should be considered as heart failure with improved left ventricular ejection fraction. This is the universal definition and the classification of heart failure. So the definition of heart failure, as you have seen from the first definition, is it says it includes the symptoms, but there are patients with heart failure who don't have symptoms, like stage A, stage. So the universal definition and the classification of heart failure includes the symptoms as well as the stage and the classification based on ejection fraction. So as you can see, the first definition is it includes signs and symptoms caused by structural or functional cardiac abnormalities, and they should be corroborated by elevated nitric peptides and objective evidence of cardiogenic pulmonary or systemic congestion. The stage, as you can see, the AHA stage, stage A, and the stage B, which is a pre-heart failure stage, stage C, where the patient starts to have symptoms, current or prior symptoms, and the other is stage D, heart failure. The other classification is based on ejection fraction. So based on ejection fraction, heart failure with reduced ejection fraction is when the ejection fraction is less than 40%, and heart failure with mild reduced ejection fraction is when the ejection fraction is between 40 and 49. Previously, this term was saying mid-range heart failure. So, but currently it's changed to mild reduced ejection fraction. This is the new change. The other is heart failure with preserved ejection fraction with the AF of at least more than 50%. So the other terminology is heart failure with improved ejection fraction. This is heart failure with baseline ejection fraction of less than 40%. And if it increases on second measurement more than 40%, this is heart failure with improved ejection fraction. So according to this definition, even if the ejection fraction normalizes in heart failure with reduced ejection fraction, we will not say recovered. We will say they are in remission stage. So this terminology is offers opportunities for more precise communication. So it's very important to know your patients from what they were having previously and how they are progressing subsequently. So the other term is they are using also heart failure with persistent heart failure instead of those patients with stable heart failure. So epidemiology, HFpEF represents at least 50% of the population with heart failure. Its prevalence is increasing, particularly over the last decade. The prevalence is increasing compared to the other form of heart failure. So on 13 community-based studies from 1997 to 2006, the HFpEF prevalence is around more than 50%, as you can see. And then community-based, and this is a proportion of hospitalized heart failure patients. So if you see the trend over 2 decades, the HFpEF is increasing over the past 2 decades. Look at the trend of F with reduced ejection fraction and the mid-range. So it is increasing. This is taken from heart failure, which was published on 2030. So there are different from patients with HFpEF are different from heart failure with reduced ejection fraction. So if we see the age, the age increases, patients tend to have more of HFpEF than HFrEF. Females are more likely to develop heart failure with preserved ejection fraction. This is just because females outlive males on the long run. Hypertension, more likely they develop HFpEF, obesity also, and diabetes. Those with coronary artery disease will likely to develop heart failure with reduced ejection fraction. So there is a new paradigm for HFpEF. It is said that comorbidities drive myocardial dysfunction and remodeling is the main mechanism for heart failure with preserved ejection fraction. As you can see, obesity, particularly among the comorbidities, obesity is the potent one. So obesity, overweight, hypertension, diabetes mellitus, COPD, iron deficiency, these are the comorbidities. So they will induce inflammation, induce interleukin-6, human necrosis factor alpha, and the others. And this will result in a generation of reactive oxygen species in the endothelium, particularly in the coronary endothelium. So they will result in reduced availability of nitric oxide, and this will result in decreased availability of protein kinase G, which results in less phosphorylation. So there will be increased tension in cardiomyocytes, as well as cardiomyocyte hypertrophy. And also you can see on this side, it will also induce this E-selectin, VCAR, and so on. This will result in mobilization of leukocytes. These leukocytes, particularly monocytes, it will produce transforming growth factor beta, which transforms fibroblasts to myofibroblasts, which results in fiber collagen deposition. So there will be cardiomyocyte abnormality and also collagen deposition as the main mechanism for HFpEF at molecular level. So when you see the mechanisms, you can see the hemodynamic as well as the cellular components of mechanisms. So left ventricular congestion, diastolic dysfunction, left atrial hypertension are one of the hemodynamic mechanisms. Also pulmonary vascular disease with right ventricular dysfunction, volume overload. And you can see also cellular and extracellular structure changes, cardiometabolic abnormalities, microvascular inflammation. These all contribute to HFpEF. So HFpEF is a separate entity. As you can see, there is a new paradigm for the pathogenesis, particularly at molecular. Hello. So what are the patterns of ventricular remodeling? So here they have compared heart failure with reduced ejection fraction and HFpEF. As you can see, heart failure with reduced ejection fraction is particularly of volume overload condition, but HFpEF is pressure overload condition. So the volume overload, so it results in increased diastolic pressure. This will increase diastolic wall stress. And a series of additional new sarcomeres, and this results in chamber enlargement. Again, the cascade continues, and it results finally in eccentric hypertrophy. But in HFpEF, as you can see, it is a pressure problem, particularly increased pressure, systolic pressure, increased systolic wall stress, prior addition of new myofibrils, there will be wall thickening, and it results in concentric hypertrophy. So heart failure with reduced ejection fraction is a condition of volume overload characterized by eccentric hypertrophy. So it results in thinning of the LV walls, decreased systolic function, enlarged LV volume. But HFpEF is a condition of pressure overload characterized by concentric hypertrophy growth, and also it results in normal sized LV cavity with thickened walls and preserved systolic function. So what are the clinical manifestations of these patients? These are the participants enrolled in the Paragon heart failure. We will see it shortly. So the sign symptoms in this particular patients were, the common symptoms were, almost all patients have dyspnea on exertion. And other patients have fatigue, particularly in this particular patients, it is out of proportion of the exertion. So the fatigue, they complain will not be explained by the exertion they have. So if you come to the symptoms, look at the JVP is not much raised, rails are not much present. So the most important symptoms are dyspnea on exertion and fatigue. So who are these patients? So this is the ASC 2016, the typical demographic and the comorbid associated HFpEF. You can see these patients to have aging, deconditioning. When you come to the comorbidity, you can see advanced age, arterial hypertension, atrial fibrillation, female gender, any kidney dysfunction, obesity, pulmonary disease, particularly COPD, sleep apnea, pulmonary hypertension. So these are the demographics and the comorbidities that are associated with heart failure with preserved ejection fraction. So what are the common participants of this condition? So particularly these patients have difficulty tolerating certain kinds of hemodynamic stress, which cause increased LV diastolic pressure. The most common stressors encountered are exercise, atrial fibrillation, hypertension, intravenous fluid, and ischemia. So before diagnosing these patients, it's always important to look for mimickers, the cardiac mimickers, that cardiac causes that could mimic HFpEF. So overt valvular heart disease, coronary artery disease, pulmonary arterial hypertension, high output heart failure, constrictive pericarditis, infiltrative or restrictive cardiomyopathy, hypertrophic cardiomyopathy, right ventricular myopathies, and pulmonary embolism. These are the cardiac causes of dyspnea that could mimic HFpEF. We have to also look for those non-cardiac etiologies that can mimic HFpEF. Those patients with obesity could have those symptoms: chronic lung disease, kidney disease, primary cirrhosis, existing compression of the LA, LV, IVC, and anemia. These are the things we should rule out first. So as you can see, HFpEF is a complex phenomenon. So there are lots of cardiac mimics as well as non-cardiac mimics. So in patients with heart failure with dyspnea, in whom diagnosis is in question, we have to use a score. There are two scoring systems: the H2FpEF score and the HFpEF score. These are well-validated scoring systems, and they are both have been compared, and they are said to be comparable in sensitivity and specificity. So how to diagnose heart failure with preserved ejection fraction? This is the HFpEF diagnostic algorithm, which is developed by a group of experts from Heart Failure Association and the European Society of Cardiology. So as you can see, if a patient has come to you with breathless, shortness of breath, you should ask history, clinical assessment compatible with HFpEF. We have to ask history, fatigue as well, and we go for standard diagnostic tests like natriuretic peptides, and also we have to do ECG. ECG could show subabnormalities, particularly if there is atrial fibrillation, left ventricular hypertrophy, left atrial enlargement, X-ray if there is any congestion, echocardiography to see for ejection fraction, and also to see chambers as well as evidence of abnormal or elevated feeding pressures. So if the pretest results is suggestive of heart failure with preserved ejection fraction, we will use this score. So PEF score. So if the score is low, you have to search for other non-cardiac causes, or non-cardiac or cardiac causes. If the score is high, this is diagnosed, HFpEF is confirmed, so we have to look for specific etiology. But if the score is intermediate, we have to go to diastolic stress test, either non-invasive or invasive. So if it is abnormal, HFpEF is confirmed. We have to go to for specific etiology. But if the non-invasive test is not conclusive, you have to go to invasive testing. So if the diagnostic test is normal, you have to look for other possibilities as well. So this is the PEF algorithm. The P stands for initial workup, pre-test assessment. So we have to assess for signs and symptoms. We have to look for comorbidities, risk factors, ECG, standard echocardiography. Maybe this time you will look for chambers as well as the ejection fraction. And later on, you might go for comprehensive echocardiography on step 2. So natriuretic peptides, you can do this step or next step. The next step is you have to look for diagnostic workup like echocardiography and natriuretic peptide score. Like I've said, comprehensive echo, which includes diastolic assessment. So the other is advanced workup. If it is not that conclusive, if your diagnosis, you can't reach on proper diagnosis, you can go to stress test. And or if it lies in intermediate range, you can go for stress test, either non-invasive or invasive. The final part is etiology workup. So when you evaluate this patient test, and the essence of ECG is to exclude arrhythmia, overt ischemia, and LV enlargement, but there is no pathognomonic sign, and the diagnostic value of an ECG to identify HFpEF is poor. So ECG could be normal in this particular patient test, but the most important indication is to detect atrial fibrillation, which is highly predictive of underlying HFpEF. So we do echo, you will see the LV size, LV function, diameter, LVH, all motion abnormalities, any valve or abnormalities or pulmonary hypertension. So the presence of structural alterations on echocardiography supports this, but its absence does not exclude HFpEF. So the lab tests conducted should include anemia. They should exclude anemia, infection. You have to determine P levels, A1C, thyroid hormones, and the like. Coronary angiography is important to detect ischemic heart disease and LV pressures, and also stress echo if the standard echo is not diagnostic. So just to go in detail to the E part, diagnostic workup for step 2. So this is the important part. So what we do on the echo is there are functional as well as morphological things we have to see. In addition, we need to also look for biomarkers. These biomarkers vary in sinus rhythm as well as atrial fibrillation. So what we see on functional assays, if we are using the septal E prime, so the issue if it is less than 7 centimeter per second, or lateral E prime, which is less than 10 centimeter per second, or average E to E greater than or equal to 15, or TR velocity of greater than 2.8 meter per second. This is one of the major criteria. So major, if you are the major criteria, each contribute 2 points. For example, from one category, if you just use only one, if the septal E is less than 7 centimeter, average E to E is greater than 50, or maybe if the TR is greater than 2.8, still the point is 2. You don't add each of them. You use a combination of science, a combination of these functional assessments, but you don't add them from the same category. So you go to morphological say, so you can see the left atrial volume index greater than 34 ml per meter square, or the left ventricular myocardial index you can see this also contribute 2 points. The biomarkers in sinus rhythm, NT-proBNP should be greater than 220 picogram per ml, or BNP greater than 80 picogram per ml. But if the patient is in AF, the NT-proBNP at least it should be 3 times elevated. So it should be greater than 360, or this one greater than 240. And for the minor criteria, like the average E to E should be in between 9 and 14, and the global longitudinal strain, which is less than 60%. So we can, in our setting, maybe I think we can use average E to E 9 to 14. And you can see the other parameters as well, the biomarkers based on whether the patient is sinus rhythm or in AF. So if the point is less than 1 or less than 1, you have to exclude it. The patient is not having HFpEF. So HFpEF is diagnostic if you have 5 or more points. The total score would be like 6. So if it's greater than 5 points, 5 or more, it is diagnostic. But if it is in the gray zone, which is between 2 to 4, you have to stress the patient, either echo stress test, or if that's not conclusive, you have to go to invasive hemodynamic test. So just for those patients where we can't reach at conclusive diagnosis or intermediate range, we have to go to stress test. So diastolic stress test, we can do echo stress test, and we can see the Doppler parameters and the tissue Doppler as well as the transmitral Doppler parameters. And based on that, if it is suggestive, we will consider the diagnosis. If it is not, still we will go to invasive test. So on stress testing, what you see is the average E to E value should be greater than 15 or equal to 15, or TR velocity greater than 3.4. If you have fulfilled this, it is confirmed. So, but if no, still you don't give up here. You have to go for invasive hemodynamic assessment. You have to catheterize the heart, right heart catheterization at rest and during exercise. So this is the diastolic stress testing, invasive one. When you catheterize, look at the patient at rest and during exercise. So the left ventricular diastolic pressure has increased from 12 to 40 millimeters of mercury. So there is marked increase in LV pressure as well as left ventricular diastolic pressure. So there is another scoring system. This one is developed in one center in one of the Mayo clinics. So they say it HFpEF score. It's very easy to memorize it. So they use the H2 is heavy, which means body mass index of greater than 30 kilogram per meter square. You score it 2, and hypertensive patient on 2 or more antihypertensive medicines, you score it 1. Atrial fibrillation gets the largest point, be it paroxysmal or persistent, they will get 3. Pulmonary hypertension, based on what we have said, so the estimated pulmonary systolic pressure greater than 35 millimeters of mercury, they will get 1 point. Elder, those greater than 60, they will get 1 point. And feeling pressure, Doppler echocardiographic, in this part, they use the E to E value greater than 9. So they will score it 1. So the total sum is up to 9. So those patients who are greater than 6 will be diagnostic. Those patients who have score of less than 2 are low likely. Those patients above that are in the intermediate range. So those in the intermediate range, again, we should stress them. We will go to echo stress, or if it's not conclusive, we have to go to invasive. So which scoring system should you use? So there I have seen a few papers. So when you see in this paper, what it says is had acceptable diagnostic accuracy in diagnosing HFpEF in Japanese patients. They compared both. The diagnostic accuracy of both were acceptable. Also, this one is the same, but what it says is HFpEF has higher discriminatory ability for identifying poor exercise capacity among patients with dyspnea. So this one is a little better, but both can work. We can use whichever is suitable for it. So what are the goals of treatment of these patients? The first thing is we have to reduce heart failure symptoms. We have to increase functional status and also reduce the risk of hospital admission. These are our goals in management of HFpEF. To date, there is no clear evidence that pharmacologic therapy, diet, or other therapies reduce the risk of mortality in patients with HFpEF. So we are dealing with symptoms, functional status, and the reduction of hospital admission. So when we see the guidelines, what they said in 2012 was no treatment has yet been shown convincingly to reduce morbidity and mortality in patients with HFpEF. 2016 also the same. In 2060, the recommendations for HFpEF were it is recommended to screen these patients for both cardiovascular and non-cardiovascular comorbidities, which if present should be treated, provided safe and effective interventions exist to improve symptoms, well-being, and prognosis. So they were addressing the comorbidities. So the emphasis was addressing the comorbidities. And also diuretics are recommended in congested patients with HFpEF or heart failure with mildly reduced ejection fraction in order to alleviate symptoms and signs. This is a class 1 recommendation. So what do trials have come up since then? So there are key large RCTs in HFpEF. This is a PEP-CHF, which used pendopril ACE inhibitor. And by the way, none of these large RCTs have met the primary endpoints. But there is a trend towards benefit, but then none of them have mortality benefit. But when you see the this PEP-CHF trial, so they use perindopril against placebo, and you can see the proportion of having an event. These patients were it's not significant, but there is a trend towards that. Charm preserved, they use candesartan. They try to see so the proportion of cardiovascular deaths or hospital admission for CHF was decreased, but it was not statistically significant. As well, the eye preserve, they used irbesartan against placebo. They wanted to see the cumulative incidence of primary outcomes. This particular study was lower in irbesartan, but it's not statistically significant. The TopCat trial is one of the well-studied one. It was studied in different parts of the world, in the USA, Brazil, and the other parties in Russia as well as Georgia. There were in both sites, it was not that much significant, but there is a trend toward this benefit. So when you see this primary outcome, CVDs, heart failure, hospitalization, or resuscitated cardiac arrest, still is better for spironolactone, but the p-value is not statistically significant. TopCat region results by region, you can see Russia, Georgia, they included lower. So this trial has come for some issues. What they said is some of the patients included in the Russia, Georgia, where they didn't meet the inclusion criteria. That means they didn't have HFpEF from the outset. And the other thing is patients, those were enrolled, were not taking the medications properly, but they were saying yes when they were asked. So that could be the discrepancy between the Americans and the Russia, Georgia. The other trial was Paragon heart failure. The primary results were recurrent event analysis of total heart failure hospitalization and the CVDs. As you can see, so the ARNI sacubitril valsartan versus valsartan. There is the mean cumulative events is lower in those patients on sacubitril valsartan, but it is still not statistically significant. Heart failure hospitalization and CVDs, same, but there is a trend towards benefit. So there is significant heterogeneity in multivariate analysis by ejection fraction and sex. So only sex and ejection fraction remain nominally significant on multivariate analysis. So what about other trial? The impact gliflozin in heart failure with preserved ejection fraction. So this was a journal released in 2021. What they found was, as you can see over here, impact gliflozin against placebo. The mean number of events per patient was reduced, and it was statistically significant. And also the cumulative incidence among those who were taking impact gliflozin was also statistically significant. So the conclusion of this paper was impact gliflozin reduced the combined risk of cardiovascular death or hospitalization for heart failure in patients with heart failure and the preserved ejection fraction, regardless of the presence or absence of diabetes. So this is one of the promising journals to date regarding this topic. So SGLT2 inhibitors, again, there is also another trial ongoing, delivered trial. The primary reports are saying it has good outcome. It's one of the studies which will come up with a better report. So this is just to show impaired preserved the impact gliflozin. Now the delivered trial is going on. So just comparison of HFpEF trials, design and inclusion criteria. As you can see, this is a summary. So the charm preserved, PEP, CHF, eye preserved, top cut, paragonate failure, impaired preserved, delivered failure. So these trials, none of these trials have made the primary endpoint, but there is a trend towards benefit, particularly the top cuts and the impaired preserved are said to be better. So effect of different heart failure therapies in specific trials aiming to recruit heart failure patients with those with preserved ejection fraction. If you compare head to head, you can see impaired preserved in the first event CV days of heart failure hospitalization was reduced like by 17%. It is very large number. The others you can see charms 5%. Beach trial 8%, the top cut 7% reduction, but the majority of reduction is achieved through impaired preserved trial. So general principles of management is just treat underlying etiology. If there are ischemia, myocarditis, also treat other comorbidities like hypertension, iron deficiency, and like they say, consider spironolactone. We will see later on how to consider spironolactone. So diuretics for symptom relief, and also you have to look for specific forms of specific etiologies like amyloidosis, if there are indications for that. So this is just the recommendation in 2021. So still they suggest for screening and the treatment of etiologies, cardiovascular and non-cardiovascular comorbidities, and the diuretics are recommended in those who are congested in order to alleviate symptoms and signs. Another thing is treatment of hypertension recommended to prevent or delay onset of heart failure, to prevent heart failure hospitalization. So they didn't say which specific antihypertensive to use. So we just continue with the existing guidelines. So treatment with statins in this particular patients. For HFpEF, particularly, you don't give a statin for HFpEF only, but you give statins when they are at risk of CV disease or with those with CV disease. Otherwise, for HFpEF only, statins are not indicated. SGLT2 inhibitors are recommended in patients with diabetes at high risk of CV disease or those with established cardiovascular disease to prevent heart failure or hospitalization. So counseling against those risk factors, these are all class 1 recommendations, as you can see. So what are the new recommendations as of 2022 ACCHA guideline? So in patients with heart failure with preserved ejection fraction, SGLT2 can be beneficial in decreasing heart failure hospitalizations and cardiovascular mortality. And so they got class 2A recommendation. MRS, particularly among patients with left ventricular ejection fraction on the lower end of this spectrum, left ventricular ejection fraction like maybe 50, 52, up to 55 like that. And on the lower end, you can, they have got class 2B recommendation. ARNIS may be considered in select patients to decrease hospitalization, again on the lower end of spectrum of ejection fraction. So particularly SGLT2 are where they have better recommendation. So how would you proceed in management of such patients? So if the patient is having congestion, we have to give diuretics as needed to alleviate the congestion and signs and symptoms. So SGLT2I has got class 2A recommendation, as you can see, ARNI, MRS, ARBs. So we don't get any recommendation for beta blocker, and the beta blockers are not studied in this particular patients. But in seniors study, which included nebivolol, it showed there is some benefit with use of this beta blocker. But in that trial, the problem is the HFpEF patients contributed around 15%, 1.5. So it's difficult to generalize that benefit for this sort of patients. So these are the drugs that are studied, even though not that much. They didn't meet the primary endpoints. These are the drugs that are recommended the current guideline. So what are other treatment options? Do you have device therapy? We have cardio-MS heart sensor, which is implanted in hemodynamic. It's a hemodynamic monitor, which is implanted in pulmonary artery, and this transmits pulmonary pressures to providers. So the champion trial said there is significant decrease in pulmonary diastolic and systolic pressure, as well as 52% decrease in heart failure-related events, an increase in days alive out of hospital, and improvement in quality of life. The other therapeutic device is left atrial shunt. So the main reason for increased feeling pressure in this particular patient will result in LA dilatation. So if the shunt to right atrium, the pressure will decrease. So there is also ongoing trial, reduce LAP 2 trial, is ongoing trial, but preliminary results suggest that this approach is safe and might improve hemodynamics. But there are concerns this will result in right atrial and the right ventricular dysfunction in the long run. So neither ICDs nor CRT device are currently recommended for these patients, although patients with LV synchrony are at increased of days, particularly in sudden cardiac deaths. So these are the devices. So you can see how they put it, implant it, and this is the left atrial shunt devices. So other treatments like vitality, right, the trial, also the deliver trial, which is ongoing. So we were waiting for the result of deliver trial. So back to our case. So a 60-year-old female patient presented with dyspnea on ordinary exertion, with worsening over time since 2 months. She also reports excessive fatigue. She is hypertensive for the past 2 years on amlodipine 10 milligram per day. Blood pressure was under 40/90, pulse rate was 80, respiratory rate 20, saturation of oxygen was 95% at female. Chest was clear, ECG was in sinus written, there were no pathologies. Echo normal cardiac chamber size with ejection fraction of 50-52. So what's the best next step in the workup of this patient? Maybe you can give your answer in the chat box. I will wait for a few minutes. Okay. 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 Lots of the participants are answering it well. So I think I'm happy that you have. Yes. Yeah. So I say lots of almost all the participants have responded to this question. So you can, as you can see in this particular patient, so we assume that this patient is having HFpEF because of the symptoms and as well the risk factor she's having, and also look at the LV ejection fraction. So we have to go for a risk score. So we can use either of the risk scores depending on that. If it is high, the diagnosis is confirmed. If it is low, you rule out the diagnosis. But if it is intermediate, you have to go to stress test. So initially you prefer the non-invasive one, and if it is not conclusive, you go to the invasive assessment. So what treatment would you start for this particular patient? You can also forward your answers in the chat box. What treatment? Okay. Okay. A, B. Okay. C. Okay. Great. So this one. Okay. So what they say is, anyways, among these, the preference would be either A or B. But if you have to start medication, the guideline says you have to start the empagliflozin because it's one of the trials that has come up with a benefit. Particularly empagliflozin among its mechanisms, the osmotic diuresis one is said to be well effective in this particular patients, along with the other energy booster, as well as the other the decreasing calcium overload in the myocyte. But this one is said to be better, and the reason is that the diuresis as well as natriuresis effect is better compared to the loop diuretics. The reason is that gliflozins in general, they work more on the interstitial rather than the plasma volume, so you will be safe regarding hypotension and vascular contraction. So spironolactone is also another option. Spironolactone is also another option. So this is a suggested algorithm for spironolactone HFpEF patients. So does the patient have HFpEF? If your patient has HFpEF, so you have to look for the top cut criteria. So the top cut criteria is your patient should fulfill all four criteria. The first is history of heart failure, hospitalization, or elevated BNP, according to the diagnosis we have already said. So the cutoff point for BNP. The other thing is the baseline potassium should be less than 5. The serum creatinine should be less than 2.5. The estimated GFR should be greater than 30. So these four criteria should be met to start the spironolactone. So take-home message. HFpEF is a heterogeneous condition. It's not a single disease. So diagnosis relies on finding objective evidence of high filling pressures, of inadequate cardiac output. Multiple mechanisms beyond diastolic dysfunction exist for HFpEF. By the way, the presence of diastolic dysfunction is not required for diagnosis of these particular patients, but you will find in the majority of patients. HFpEF diagnosis has improved, and it involves now the physical, echo, NPACE, cardiopulmonary exercise testing. Management emphasizes on aggressively treating comorbidities. To date, no treatment has been shown to convincingly reduce mortality and morbidity in these patients. Also, improvements have been seen for some specific phenotypes of patients with overall HFpEF umbrella. Thank you very much. If you have questions, I will go.
Thank you very much, Dr. Elsah. That was an excellent presentation. Now we can, the floor is open for discussion. There have been a few questions on the chat box. Until I read that to you and you answer them, the other participants can raise your hands and we will give you a chance to ask questions. So the first question is prevalence of HFpEF as compared to HFrEF, and also can you comment on the prognosis of HFpEF as in comparison to HFrEF, maybe specifically in acute presentations? Yes.
Okay, the prevalence of HFpEF compared to heart failure with reduced ejection fraction, as I've already mentioned, now the HFpEF is increasing. In fact, it's now more than 50-55% of patients, particularly those of elderly patients, are having HFpEF compared to those patients heart failure with reduced ejection fraction. Even in those patients with less than 40 years, if you see, the trend is towards heart failure with preserved ejection fraction, particularly among obese patients. So overall, when we see that the prevalence is increasing among such patients. And the other question was regarding prognosis. So morbidity and mortality in this particular patients is to be comparable, but still the mortality is higher in patients with heart failure with reduced ejection fraction. But the hospitalization as well as the other quality of life is comparable in both settings, but the mortality is still higher in heart failure with reduced ejection fraction. So like the 5-year mortality is almost half, like out to 50% among almost heart failure patients, but it is higher in patients with heart failure with reduced ejection fraction. Thank you.
Thank you. Until questions are answered, please participants fill the forms for attendance forms for certificates. So the second question is in relation to what you just discussed. Is there any data in Africa regarding the epidemiology of HFpEF that you came across with?
That's a problem. So I was trying to search for data in heart failure. Actually, in Africa, there are few studies from Nigeria and also a few studies from South Africa. They are institutional-based studies. And also globally, particularly in the continent, there is a problem with heart failure research. So we don't have much data regarding this particular condition. But there are a few reports from Nigeria and South Africa.
Yes, thank you. So the other question is about the medication. So what's your comment on the use of beta blockers in HFpEF? What are there any studies regarding that?
Yeah, okay. Thank you very much. This was a very nice question. So regarding the trials, large trials conducted in HFpEF patients, I have already discussed, but the beta blockers were not among them. But as I mentioned, there is one study, the seniors study, which studied the benefit of beta blockers, particularly of nebivolol. So in that study, there is a benefit of mortality, reduced mortality, hospitalization, and all-cause mortality. But the problem with that study is that the proportion of HFpEF patients included were less than 15%, 1.5. So it will be difficult to generalize.
Thank you.
Thank you.
So there are two questions regarding the association between HFpEF and the kidneys. So is there a link between HFpEF and CKD? And also, can you comment whether there is an increased prevalence of cardiorenal syndrome in HFpEF?
Okay, the first question. In particular, one of the comorbidities for HFpEF is CKD. So they are very much related. But regarding cardiorenal syndrome, I didn't come across any paper like that. But CKD as well as HFpEF are related. It's one of the comorbidities which could be involved in the pathogenesis.
Yeah. So specifically to top cuts, so there was this regional difference in the benefits for patients from MRA. So what was the presumed cause for this regional difference? Is there any patient characteristics related difference, so that can we extrapolate these results to our patients?
Yeah, in top cut trial, there are regional differences in those of in the US, Brazil versus those of in Russia and Georgia. What they said is the reason is one, those patients in the Russia and Georgia who are included in the trial, they didn't actually have HFpEF. What is that one reason? The other thing is that patients who were enrolled in the study, they said they were taking the medications when inquired, but actually they were not taking the medication. So that's the problem that they highlighted. But regarding applicability, I think we don't have any class 1A recommendation for any of the drugs. We have a good hope that the drugs will be coming up. Previously, we don't have that much hope. So this area was not this area was not much discovered, but I think we can use the top cut criteria to start the spironolactone. The problem with empagliflozin is it's very costly in our setup, as you know. We can't start right and left, but spironolactone is available. We can start with low dose and see the improvements if they fulfill all the four criteria for top cut. That's my suggestion.
Thank you. There are two questions from participants who are writing about their patient experience. So one of them is what to do in cases where ejection fraction is like borderline 48, 49, 50. Is there any additional way of differentiating between HFrEF and HFpEF, or in which kind of treatment would our patients benefit?
So this is a very nice question. So the first thing in the entry point is the ejection fraction. So ejection fraction 50, less than 50 is heart failure with reduced, so we mild reduced ejection fraction. If it is more than 50, it should be considered as HFpEF. So the current recommendation is if they have heart failure with mild reduced ejection fraction, the treatment is also those of heart failure with reduced ejection fraction. That's the current recommendation. If they are more than that, that's how we treat. So echo should be properly done and should be repeatedly done. If that's not, there are some confounding issues, but still that's the recommendation they're saying. So like 41 to 49 is mild reduced ejection fraction. More than 50 is also patients with HFpEF. So the management would be like that.
Yeah, thank you. So the other question is, I think, investigation and management of HFpEF in patients with suspected coronary artery disease, like in patients with high risk to coronary artery disease. Should we do angiography prior to starting treatment? And is there any peculiarity in treating these patients?
Yeah, thank you very much. So once you diagnose HFpEF, the next step is to uncover the etiology. What is the underlying possibility? So if the patient is having HFpEF is confirmed, you have to go to etiology. So overt coronary artery disease, it should be treated.
Yes. Thank you. So I think maybe the last question would be, there are a few similar questions about duration of treatment. I think the answer would be very short for this. How long should we give SGLT2 inhibitors or spironolactone if we decide to start them?
Heart failure is a progressive disease. What's peculiar to heart failure with preserved ejection fraction is they will be stable for longer time. But there are some sort of patients who go to with mild reduced ejection fraction or heart failure with reduced ejection fraction. So the treatment is longer time. So you continue treating once you start.
Yes, there are there are participants who have raised their hands. Can you please unmute your mic and ask your questions? Maybe we'll allow 1 or 2 questions from this. Dr. Elsah, there are a few questions on the chat box. One of the questions is, is there any dose increment for spironolactone where patients might get benefits? Should we escalate? That's one of the questions.
Yeah, so these and other questions I will try to answer. So yes. the starting dose would be like 25 milligram, and it should be escalated up to 50 milligram. Maybe we can start with 12.5 milligram as we are practicing with other patients. So the dose should be increased. So that's how they started in TopCat trial. So the dose should be escalated based on the symptoms. Maybe the other question is the mechanism of this SGLT2 inhibitors in these particular patients. As I was trying to mention initially during the presentation, the main mechanism of help in this particular patient is the osmotic diuretic effect of empagliflozin. So it is natriuresis and the diuresis effect is said to be one of the mechanism. The other thing is in this particular patient is the sodium potassium exchanger is upregulated. So this will result in increased intracellular calcium load. So by these drugs will reduce the intracellular calcium load. And the other mechanism of help is HFpEF patients are like type 2DM patients, they are insulin resistant. So the energy utilization is reduced. They rely on fatty acid. So if we use these drugs, they will shift the energy utilization from fatty acid to glucose. So by doing this, they will make the myocyte more efficient. So these are the 3 main mechanisms for SGLT2 inhibitors. The other question is the HFpEF in MR. Regarding the ejection fraction and so on. So if you have overt moderate to severe mitral regurgitation from the outset, this is not HFpEF. So this should be considered as mitral valve disease of moderate to severe intensity and managed likewise. So this is one of the exclusion criteria to not include them. The other question is one of the participants inquired if what drugs should be changed if a patient has gone from HFrEF, heart failure with reduced ejection fraction, to HFpEF, heart failure with preserved ejection fraction. So the main thing is we have to go back to the definition. If a patient has initial ejection fraction of less than 40, and if the ejection fraction goes beyond 40, 50, or 60, he will be labeled as heart failure with improved ejection fraction. So he will not be renamed as heart failure with preserved ejection fraction. So the management, regarding the management, the recommendation is you continue the management likewise. So the current recommendation is there is no place to withdraw heart failure medications. So there is no recovery from heart failure. The term used by universal definition is what we call heart failure in remission. So if the ejection fraction goes beyond 40, we will say heart failure with improved ejection fraction. But regarding the medication, you continue the medications, and that's the way we continue. The other question is, okay, is there any specific ECG sign to differentiate, demarcate heart failure with reduced ejection fraction from heart failure with preserved ejection fraction? This is a very nice question. So there is one study, the MESA study, a multi-ethnic study of atherosclerosis. So they found ECG criteria that suggest future development of either category. So those patients with prolonged QRS, left axis deviation, right axis deviation, prolonged QT, LVH, STT wave changes, and left bundle branch block are likely to develop heart failure with reduced ejection fraction in that study. And other patients like increased resting heart rate, patients with increased resting heart rate, abnormal P wave axis, and abnormal QT, they are said to be more likely of developing HFpEF, heart failure with preserved ejection fraction. So this is from the MESA study. The other question I got was heart failure with preserved ejection fraction, if they are not in congestive states, is there a place for diuretics? So diuretics is for symptomatic benefit. So if they are not congested, you don't have to start diuretic in such patients. Rather, you will try to start other medications of those who are studied in, which are studied in the trial. So this is, I think, one of my response for the questions raised.
Okay, thank you. Maybe one last question is, where natriuretic peptides are not available, can we diagnose HFpEF with the rest of the, like with symptoms, ECG or echo?
Okay, so yes, we can diagnose, but there are places where the parameters for echo might not be diagnostic, like I said earlier. The diastolic parameters for echo, you might not find them universally. And the other issue is sometimes technically it's difficult to perform the diastolic parameters, and the interpretation might be difficult. So in such scenarios, we have to use BNP, but the absence of BNP doesn't rule out our diagnosis for HFpEF. So we can use the signs and symptoms plus the ejection fraction plus evidence of abnormal or elevated feeling from echo. So as you can see from the algorithm, there are functional, morphological, as well as biomarker parameters. So it is the cumulative sum of these parameters that we use to diagnose HFpEF. So we can go without BNP. Thank you.
Thank you very much. I don't think there are more questions. Okay, so thank you very much, both the presenters. It was an excellent presentation. Thank you, our participants. We would like to extend our gratitude to both the Ethiopian Society of Cardiology and the ENAOC team for giving us their platform to present and do this. For the past 3 weeks. We had 6 sessions. So this is the last of the pre-CME sessions, and thank you very much. Thank you for participating actively. We would send your certificates, both certificates, via email, and please give us a few weeks so that we can get time to do that. As I said earlier, the recording would be available on YouTube in a few days. Thank you very much, everyone. Have a good day and happy holidays.
Thank you very much. Thank you.
Have a nice time.